You know, Jason, when I came up with this idea to have a podcast with a chiropractor and a physical therapist, I really thought we were going to beef more.
Beef? About what?
You know, about how much better respected PTs are than chiropractors.
But Kathy, you're so likable. Why would I ever beef with you?
Come at me, bro.
Huh?
Yeah, let's do it. Let's get it out of our system. It's time to show people how different we really are. No more kumbaya stuff.
Okay, I agree.
No agreeing. It's time to argue.
Okay.
Not okay.
Fine.
No. Today we're going to talk about how a physical therapist and a chiropractor might approach cases differently. And you are not just allowed to say, me too. Don't do it. Don't do it, Jason.
Me too. This is the pitch. What happens when a chiropractor and a physical therapist get together to make a health and wellness podcast?
But chiropractors and physical therapists don't like each other.
Oh, think again.
I'm Dr. Kathy Lynch, physical therapist who likes to help people move and get stronger.
I'm Dr. Jason Young, an evidence-based chiropractor who uses humor just as much as adjustments to help people get better.
Welcome to the Pitch Podcast.
Remember, there's no I in pitch. Let's get ready to rumble.
Let's
go. Now, welcome back to the Pitch Podcast, where chiropractors and physical therapists don't get along.
That's right. We're going to beef today.
Not today. They don't get along. So, yes, today we will be battling for clinical supremacy.
That's right.
Yes. Mm-hmm. So the loser has to become a massage therapist. No, I'm just kidding. I love you, massage therapist.
Has to become a real doctor.
Oh my God. Oh, could you imagine if it was like, terrible. Now you got to go to medical school. Yeah. There goes the next 12 years of your life. Right? I might not even have 12 left in me. I don't know.
And $9 million.
Yeah, $9 bazillion. Yeah. Oh, enough student loan debt to go around.
That's right.
Yeah. So, Kathy, let me ask you this question. Why didn't you become a medical doctor? I mean, I've heard your story before. Yeah, Did it cross your mind?
No. And, you know, I look at it now and I'm like, maybe I could have gone to med school. Mm-hmm. Everybody in my family, all of the extended family, everybody in my family was all in finance or they were lawyers. No,
and you were an accountant originally.
I have my accounting. My dad scared the heck out of me and my two brothers. And we're like, he said, you got to get an accounting degree. You can always have a job. He just wanted to make sure that he did not have to pay for us the rest of our lives, basically.
Yeah.
And he's like, you'll always have a job. Mm-hmm. He did not care if we liked that job.
Yeah.
He just wanted us to be off his payroll.
Well, he wasn't wrong. You became an accountant and now you have a physical therapy job.
That's right.
So point dad. Yeah.
But really point game set match mom in high school, she said to me, I could see you in sports medicine.
Really?
Yeah.
All right, Mom.
Mom knew my heart. Mom knew me. Right?
Cool.
Dad was just like, I don't want to pay your bills.
Well, and you got to make both of them happy, right?
Yes.
You became an accountant and a physical therapist. And so, weren't there a lot of voices in your life saying, you should give chiropractic some serious thought?
I don't think we had a chiropractor in our town.
Well, you weren't from the Midwest. No, I'm just kidding. So, yeah. Well, shoot.
Yeah.
I never wanted to go to med school, like not even once. Mm-hmm. And it was because I just wanted to be able to practice the way that I felt like practicing. Mm-hmm. I actually got into healthcare because I wanted to own a business. Yeah, I was going to business school. Okay. And I thought, I want to own a business. And then I was thinking about what kind of business could I have? But I knew that I wanted a business where I was helping people every day, not just like, stacking cash for myself. Maybe one day I'll have that business. Yeah, right.
Still looking for that business.
No, but I thought being a chiropractor would probably be easy, right? So, yeah. But so that was my gateway into this. Was I wanted to own and operate a business, a brand, and everything like that. And chiropractic has always just been a part of my life, and so that's what got me to it. But sometimes people, I don't know. I think sometimes people look at nards like us And they're like, these are just people that couldn't become medical doctors. Well, some of us are just people who never wanted to be medical doctors,
is true.
right?
This is true.
I can do everything that I want to do with patients. So, well, today's show was your idea.
Yeah.
You wanted to kind of go through and highlight maybe some of the ways that we do things different.
Yeah.
And so you challenged me to a fight in the beginning of the show. Let me take off my rings real quick. No, but I don't think that's the spirit of this, that we're trying to fight. We're just trying to highlight, where do our minds go first in terms of when somebody comes in. So, yeah.
I've probably said this 5 times in this show that I just feel like our professions are so alike, but people think we're so different, but we're really so much alike that I thought, hey, let's highlight what we do differently and how we look at a patient differently. And I thought that would be maybe, Amy Clem would like to hear about that.
Yeah.
Randy, shout out to Randy. Randy is a very loyal listener.
Shout out, Randy.
Yes.
Yes.
So,
and she's also very good at selling commercial insurance.
she's very good at that too.
I just switched over to her. So good stuff. 5-star review for Randy, Farmers Insurance.
That's right.
The Hennessy Agency. Now they owe us money.
Yep.
For endorsing them on our show. Yeah. That's what we should start doing. We can just pick our sponsors.
We'll pick you.
Yeah. We're sending you a bill. Okay. So net 30 terms. Yeah. Just trust me. It's going to be great.
It's going to be great for you and for us.
You'll get a customer maybe. So no, we would never, unless we did. Yeah. Okay. All right. So how do you want to do this?
Let's see this. Give me, in 2 minutes or less, what does a chiropractor do? And if you asked 10 people on the street what a chiropractor does, what do you think they would say?
Well, the first thing that popped in my head when you said that was some chiropractors only spend 2 minutes or less. And that's it. Yeah. So it's a great question because I think there's a lot of ideas out there about what chiropractors do, what they don't do, what they can and can't do. And I think it's important for people to realize that there's really kind of there's lots of different types of chiropractors out there, but there is kind of a split in the profession. There is a very vitalistic portion of chiropractic, which sometimes people think is much bigger than it really is. It's only about 20% of the profession, and they're focused on some things that I would consider to be a little woo-woo, right? In terms of if I give you an adjustment, you don't need a vaccine and things like that. And then you have the other 80% of chiropractic that is really evidence-based neuromuscular skeletal conditions.
Right.
So we're talking treating back pain, headaches, sciatica, things like that. And we tend to go to manual therapies such as spinal manipulation, extremity joint manipulation. And then we also do like some rehab, lifestyle coaching. Some people get into nutrition if they have extra certification, those kinds of things. That is the vast majority of what it's the vast majority of what the vast majority of chiropractors do. The ones who are on the fringe are the ones who get the most focus. So, come at me, bro. You can fight me if you think that I'm incorrect after 20 years of like working at every level of the profession, including, education. So anyway, what do physical therapists do?
Well, actually, first, a side note.
Oh, wait. Okay. Yeah.
Last week I worked down in Eugene, Tracktown.
Oh, yes. Down there with Robin?
Yes,
Nice.
exactly. And Don was there.
Oh, sweet.
Yeah. World Championship.
Like a Pitch Podcast reunion.
It was without you. Next year. I
was at my daughter's wedding.
I know. That's so exciting.
Yes. Shout out to the new Livingstones.
Oh, the Livingstones.
Yes.
A happy couple.
It was great.
So fun.
Anyway, but more important thing, tell me about your track meet.
The U20s track meet. World Championships. So kids from all over the world came. And there was an administrative issue that happened where they didn't have enough athletic trainers that they recruited on staff to man the track field of play, basically. And so the lead medical people came to us and said, we need to put some more providers out. We need more medical people out there. And the person in charge of the massage therapist was like, well, who can we send? Well, look, chiropractors aren't doing anything. Let's send the chiropractors out there. Because we were in the tent. In this tent is chiropractors, massage therapists, and PTs. And so, I look over, the massage therapists are busy. I mean, they're just getting, kids are coming in, they want flushes. And so when all massage therapists are busy, if there's overflow, PTs will do massage. We'll jump in, right? But when someone comes in.
They're just sitting there playing Uno.
When somebody comes in and they need a massage, and the chiros are like, oh, no, I'm a chiro. You're going to have to wait. Not all, but most will be like, yeah, you can see those guys when they're ready. So they sent out the chiros, which was, they got the luck. They got the good draw, though.
Get out there, chiros.
Yeah, so they stood out there with their red medical vests.
Yeah.
Making sure nothing happened.
Yeah, and they were probably so smug about it, too. Oh, yeah, they pulled us away from what we were not doing and just put us out here ready to deliver an upper cervical adjustment at the drop of a hat.
And it's really funny, though, because I did get stationed out there at one point, and I was telling people at my gym class the other day, and one of my clients, longtime client, hilarious, she goes, what would have happened if you went out there? Were you going to take your TheraBand with you? It's true. Like, I know some first aid, but I would have been looking around for the AT all the time.
Yeah. Well, and this is, so first of all, I think one thing that's really important is one thing that's cool about you and I is we don't have to take ourselves too seriously, right? And it's fun to be able to laugh about these people and these things. There's PTs out there, there's chiropractors out there who are very versatile and who do extra training. There's been this video that's gone viral this week. It's a pediatrician, and he's like, chiropractors should not be doing sports participation physicals and blah, blah, blah. And he goes into all these reasons, and some of them are very valid. Like, he talks about how for some of these kids, it's the only healthcare intervention that they get throughout the whole year, which is true and a shame and should definitely not be that way. But he was like, yeah, they just have no training in how to do it and everything, because there is really, in a pre-participation physical, there's only one part that's really, really important, and that is the cardiovascular screening. But, the crazy thing is, like, you can learn how to do a good cardiovascular screening. And he's like, but they don't have access to any of the special testing or, bro, we do. You know what we do? We send them to the pediatrician. That's what we do. We send them to you, right? We send them to you. And you can't get in to see your pediatrician for 6 months, and you need a sports physical. It's like, there's some overflow, and you can do a good, competent job. Like, I cheat, right? I have a stethoscope that identifies murmurs, and it's connected to an app, and I can even record that exam. So I have several people that I've, we've caught these things, and I send them to their pediatrician. I send their pediatrician the recording of the exam so that they can hear it.
Wow.
We have kids that we've sent for evaluation for Marfan's or other connective tissue disorders and stuff. Yeah. And so it's like this idea that, you're not trained to do that, right? And same with physical therapists. There's physical therapists out there that are trained to be on the sideline doing sports medicine. Yeah. And they're good at it. Yeah. They're darn good at it. Yeah. Right.
I will say I've done other events where it's more like the pro level, older athletes, and the chiropractors are actually the most popular people besides, massage.
We're so good looking. That's what it is.
Yes,
it wow, is. I'd like to be treated by that attractive provider over there.
But the elite athletes, like they love to come in and get their spinal manipulations before they compete. That just kind of gets them primed and ready to go. So it just was funny at this event.
Yeah. Get out there, chiropractors. Get out there. Get the red vest on. Yeah, I'll tell you.
Don't touch them and something happens.
So I'm still in my recovery from my surgery, and I haven't been able to like really work on patients. I've been using like an adjusting tool and low key hate it.
Yeah.
Like, I mean, and it is what it is. Like I have loved being able to interact with patients again and like go through all the problem solving and, you know, all that kind of stuff. And, you know, we do good treatments with that thing, but man, I want to adjust somebody so bad. So bad. So
you got a couple more weeks before you can.
Yeah, not till September.
All right.
Yeah. Womp, womp. Okay. I did have one patient who tried to talk me into it, which I was like, are you kidding me? They were like, oh, that's it? That's all? And I was like, yeah, that's the best that I can do right now. They're like, well, I don't feel any different. It's like, I don't know, come back in 4 weeks, I guess. And I was like, listen, I would love to adjust you. And they're like, well, could you just try it? Could I just try it? I paid $8,000 to have a robot go down and like fix me. And you just want me to put all that on the line because... Yeah, and they weren't even in pain. That was the thing. It was like wellness care.
It was wellness.
Yeah, it's kind of weird. Some people are a little obtuse. Yeah, but I love them anyway. I love them. So, yeah.
Okay, what does a PT do then?
Yeah, what does PT do? What are you doing over there?
What are you
at
people?
Encore Physical Therapy, PT is so good you're going to want more. What are you doing?
More. Yeah. We like to think of ourselves as musculoskeletal experts, movement experts, function. We like the notes that we have to write. We have to have functional goals.
Yes.
So what we want to do is get people back to functioning.
Yes.
And back to doing the things that they love to do, but also the things that they need to do to survive. Get up and down off the toilet, get out of bed, roll over in bed, those kind of things.
Do you think it's more important to be able to get on the toilet or off the toilet?
On.
Okay. Yeah. I would agree with that.
Yeah, because if you can't get off, then you just sit there till you got to use it again.
Yeah.
Right? Yeah. But somebody can bring you food.
I like your description. I like your description of what PTs do. And it makes me think of something with the goals, right? Because I think
we have to write goals.
Well, do we? We don't have to. Like, it's not. So this is coming from a regulatory point of view. Okay. If I had somebody who I was reviewing their records, maybe they had some discipline or something like that, or they had done some sort of violation, very common that we would review their notes. If goals didn't show up in there, we're not going to be like, bro, you can't practice anymore. Okay. Right. I don't know. Is it that way for physical therapy?
We have to have goals in our notes.
Yeah.
And I think
it's best practice for sure.
It's best practice. And I think insurance looks at that to see if they're progressing.
Okay. Yeah. Well, yes. And you do need outcome measures, right?
Yeah. We got
those.
So
like a survey or something like that. But I was just thinking about the idea of how, this is going to sound bad, but how useless it is to use pain as an outcome measure. It's just, it's not useless. It's just not very useful.
Right.
Because like imagine one day I'm laying on my deathbed.
What's your pain?
The time is getting close. And my biggest regret was that we couldn't get my pain level from a 5 out of 10 down to a 3. I love you all. Goodbye. No, nobody's saying that, right? And so it's like, that's not a goal that really matters. It matters because like people don't like pain. It's uncomfortable, yada, yada, yada. But like, I might be on my deathbed saying, man, I just really regret that I just never got back to a point where I was healthy enough to go and do the Iditarod. Right. Or to play with my grandkids or to run a marathon and the functional goals are what's important.
Yes.
Right. Or people might have regret about I had to retire early because I couldn't do this or that, or I couldn't play enough pickleball to, you know, impress my friends or whatever. Pain, not so much.
Right.
Death fixes pain, actually.
That's right.
But it doesn't fix those other things.
Plus, pain is just weakness leaving the body.
Yeah, right. I love that. You know what else I love? I love it when people rhyme. And that kind of makes it true. Like, no pain, no gain. Oh, yeah, that's totally true because it rhymes. right? Like, let's try that again. No pain, Rogaine. It's like, I guess that's true too.
It must be.
Yeah.
Sounds right.
Yeah. So it's like, I didn't have pain, and yeah, I've got a fuller head of hair. Oh, goodness. But yeah, we can agree. Oh, I'm not allowed to agree.
We're not agreeing
I'm sorry.
today.
No.
Today we're not agreeing.
Yeah, well, okay, let's disagree. I will say this. Chiropractors could do better with the goal thing in terms of creating functional goals.
Mm-hmm.
I have really been trying to train myself to move away from talking a lot about people's pain.
Right.
I will talk about it in the first visit because it's what brings people in.
Yeah.
But I don't necessarily feel like I need a number. I need to know one of three things. Is it mild? Is it moderate? Is it severe?
Mm-hmm.
And then when it comes to intensity, we don't really touch that much after that because I want to know, how's it impacting you? Like, is it making it so you can't sleep? Is it making it so that you can't go and do recreational activities or work or whatever? Right. So, yeah, I like that about you, physical therapists. You're focused on your goals.
We are function forward.
You function forward goals. Function forward, funky, funny, fresh, fantastic flapjacks.
Physical
therapy.
Physios.
Yeah.
I think another thing that kind of sets us apart as professions is that PTs kind of work in all different settings. Where, as far as I know, and I make an assumption, chiropractors are technically usually just at an outpatient setting clinic.
We're mostly in Walmart.
Yes. And airports.
And airports, yeah. Yeah, but you're right. You're right. Yeah. Primarily in private clinics, right? That is expanding some. Probably the biggest area of expansion recently has been the VA.
Oh, okay. Nice.
So, yes, there's quite a few. There's even like some VA residencies for chiropractic, which is a very rare thing. It's one of the big distinguishing things about chiropractic. One of the things that's attractive about the profession to some people is there's no residency. You get your DC, get your license, get out there, and you start saving lives. No, but there's more of those opportunities popping up where you can do like a residency or a fellowship at like a VA hospital.
Nice.
But you're right. For the most part, we're mostly in private clinics, and mostly those clinics are owned by chiropractors. So there's some integrated practice and everything like that. But I would say that the average chiropractor gets kind of envious of how physical therapy is integrated.
Yeah.
More into the healthcare system, which is cool.
Yeah. Yeah, you'll see PTs in a hospital, in a skilled nursing facility. I was just listening to another cool podcast.
Is there another cool podcast? Oh.
Just one.
Wait, are you talking about this one?
No.
I'm so confused. There's more than one cool podcast out there.
Yeah.
Wow. Okay. Go ahead.
Where this PT is kind of embedded in the military. Special forces.
Yeah.
So, helping them through workouts and helping just keeping our soldiers at top, top of their game.
Sweet.
Basically, they're, tactical athletes is what they call them.
Oh, yes.
Yeah.
So, I when I graduated from chiropractic school, there's a few months that I had to wait in order to get licensed just because of when they offered exams, when scores came back. And so I had to figure out a way to feed my family. I had my wife and my 2 daughters at that point. And so I had like 3 or 4 months where I had to figure out what to do. And I was actually thinking about working with the military.
Oh, nice.
Yeah, I was thinking about working with special forces, specifically on like techniques for like breaking necks.
Yeah.
Yeah. And I was thinking like, step 1, quietly approach your subject, preferably from behind, outside of their 120 degrees of vision. Okay. Step 2, get close enough to reach like head, neck, all those things. Step 3, start to work on the shoulders. Like get them relaxed.
Yeah, gotta
like
relax them first.
Work some on the cervical paraspinal muscles.
Myofascial release.
Yeah. Step 4, have them take a deep breath. Right? Really like get them to relax. Get them to loosen up, right? Like a step 5. Right.
Is that for death? Is that the
Yeah, to kill him.
Okay.
To kill him. Right. I now was thinking, and I'm so glad that I can finally talk about this because I seriously had this thought. I could do this. And I thought it would be so funny just to make the video, right? Because people would laugh at that. But then I thought, man, then like, what if this gets out and people are like, oh, that's the chiropractor that kills people? And, so now 20 years later, I find out that just all chiropractors are out there killing people. So I should have made the video.
Those are the stats.
No, just kidding.
Yeah.
No, chiropractors aren't out there killing people very much. But yeah, that would have been awesome. Take a deep breath. Right.
I'm only here to help.
Die. Yeah. So anyhow, but yeah, so you don't find many embedded chiropractors in the military. That's what I'm saying.
Yeah.
But the VA system, one of the things about the VA is the VA does not have a practice of like integrating pseudoscience into the healthcare system. And so I think it's a really good place to look for what kind of things are like have some support, some science behind them. They utilize PT heavily, especially on the rehab side. I know some PTs who have done really great work with like amputees, people dealing with PTSD, which I think is a really interesting thing. It's like physical therapy for PTSD. And it's like, so there's for some of these mental health conditions, being able to have control of your body and everything like that is therapy. It's like when you have access to all of your physical faculties and everything like that, it allows you to overcome a lot of this mental trauma. So it's neat stuff. I like you, PTs. You're okay.
I like you chiropractors. You're fun guys and women.
Yeah. Women, we got some of them too.
Yep.
An interesting thing is about chiropractic is traditionally chiropractic. The chiropractor is an older white man, but there's a rapid switch in what the average chiropractor looks like.
Okay.
About half of chiropractic students are women.
Wow. Okay.
Yeah, which is pretty awesome.
Yeah.
Yeah. It's certainly not the case in all professions, especially not all healthcare professions outside of maybe nursing, which is it's still predominantly women.
Yes.
But yeah, so that's kind of a cool thing, I think.
That is cool.
Yeah. Yay, chiropractors.
Cool. So let's talk about where we do overlap.
Okay.
Right?
Let's do that.
So we both treat low back pain, neck pain, shoulder, hip, knees, sports injuries, those kind of things.
Headaches.
Yeah. Yep. No doubt, for sure. And we do both use exercise.
Yes.
That is like my major modality.
That is an afterthought for me.
Yeah, I was going to say, I mean, you use it, but like, would you say that your, primary modality is a manipulation?
Yeah. Well, and we, and I think it's interesting because we use all these tools, but we don't use them all the same way. And I think another really interesting thing too is that I think there should be a paradigm shift whenever it comes to I will call it manual medicine or physical medicine, right? Which is your chiropractors, massage, physical therapy, all those kinds of things. And that is really this idea that there isn't really research out there that's like chiropractic is what's good for patients or physical therapy is what's good for patients.
Yeah.
It is it's the treatments that exist within that scope that are good for patients and for different types of patients. So, for example, I can do a manipulation. You can do a manipulation. Yeah. So, research done by physical therapists that shows efficacy for manipulations, that it's about the treatment and the patient, not about so much the provider.
Right.
Now, there's different skill levels and we can get into all that. But I think that's a really important thing. And so there is a standard of care for things like low back pain, for headaches, for things like that. So if it's good for you to have a patient do exercise for low back pain, it's also good for me to have a patient do exercise for low back pain.
Yes.
Because it's about the patient and the condition and not so much about who's telling them to do the exercises.
Right.
Our skill level at selecting those exercises or facilitating them or teaching them, that might not be equal. I know your setting is different than mine.
Yeah. Right.
We got these little teeny tiny rooms.
Yeah.
And there's no treadmills.
Yeah.
Do you have a treadmill in your clinic?
We do have a treadmill.
Yeah, you do. And so I think that's where a lot of the opportunity exists whenever it comes to teaching patients. And so teaching patients and helping patients. So.
Yeah. Yeah. I mean, because we both, wouldn't, again, make an assumption, but I know just talking to you that when a patient comes in, the first thing we do is we're doing a movement assessment.
Yeah.
We might do it differently, but we just need to see how this person moves first.
Yeah. So my movement assessment, there's really two parts of it. And I'm talking about movement assessment outside of like orthopedic tests.
Okay.
Right.
Yeah. Right.
So my first thing is actually whenever I do vitals.
Yeah.
So usually when I show up, my patient is already in the room. So I haven't seen them walk in or anything like that. My assistants have brought them back and I show up, introduce myself. We start doing the history, talking about what they have going on. And then, so when we do vitals, vitals consist of, blood pressure, height, weight, respirations, things like that. So we're going to get up out of that room and we're going to go down to where I have like the strip on the wall that I can measure people's height. Yeah. We got a scale down there. Okay. And that's my first movement assessment.
Yep.
Is I walk ahead of them for that so that they know where we're going. But then we measure height and weight. And then when we walk back to the room, they go first.
Yeah.
Or I sprint down the hall, turn around and I watch them walk, right? So now it's time to look at your gait. Because it's kind of challenging to really evaluate somebody's gait if they know that they're being evaluated, because now it's like, well, now I got to do my cool walks, right? Or my high steps, my butt kickers, right?
Or I might even limp even more.
Yeah.
I need you to believe.
He's looking at me. Yeah.
I need you to believe that I'm in pain.
So that's the first assessment that I do, is watching that gait. And I do that on everybody. I don't care if you have a headache or whatever. There's no reason for me not to assess your gait, because you're going to be gating your way down the hall. And then the second one is, of course, we're going to do range of motion for whatever the affected part is. So, So tell me about your movement screen.
Yeah. So PTs, most of us PTs are not rich enough to have assistants.
Yeah, I forgot. We like in the mornings, usually I have trouble opening the door because we just have piles of gold coins. And it's like, who left the gold coins in front of the door? Oh, I really got to push to get this thing open. Right. Oh, yeah.
So I have to go get my own patient.
Okay. All right.
So that's when I watch them walk.
Okay.
I really love to see them get up out of a chair too. That's my first like, okay, how are they getting up out of a chair? And then we'll kind of walk together, and sometimes I will walk backwards so I can watch them move if I know that it's the knee or ankle or hip or something. So plus walking backwards is a skill that I want to keep. And
there you go.
I practice.
And it kind of demonstrates your movement dominance. It's like, look, guys. Oh, look, you only walk forward. Look at me. I walk backwards. Whoa, 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 whoa. Yeah, I know how you roll. Okay.
Showing off. I just wanted, I wanted to know how cool I am.
Well, and I know from the walking episode that we did that backwards walking is a cool thing at Encore Physical Therapy.
It is a cool thing.
That's what all the cool kids are doing.
Yeah.
The Aarons, the Nathans. Okay, gotcha.
That's right.
All right.
Yeah. So, so that's obviously the first thing I'll do, and they don't even know I'm watching. It's covert. Now everyone that's listening knows I'm watching.
Yeah, totally.
All the time.
And then then you start working on their shoulders, and you're like, take a deep breath. Oh wait, it's different. You're talking about patients.
Yeah. No,
okay,
these are patients. We don't kill them.
Not enemy combatants. Go for it. Yeah.
So after I've, taken the history and one of my questions is what hurts the most? What movement, what position, what hurts the most? And, then I'm like, what makes it feel better? And so secretly, I think if they say, stairs, going upstairs. So I file that behind and I'm like, we're going to go do some stairs.
Yeah.
I set the tone early that this is not a friendship.
Yeah. I'm not your friend.
Pick your words wisely.
Oh my gosh.
No, but I want to see like, okay, why does this hurt so much? Where does it hurt? Why does it hurt? So yeah, that's my other movement assessment. And squat, usually it's squats too.
Yeah.
Like, oh, my knees hurt when I squat. So I need to see a squat.
Yeah.
Yeah. But also along with you, like range of motion, those kind of things for sure.
Question. And I think that's wonderful from a movement screen standpoint. Do you assess for yellow flags?
Yes. I mean, well, red flags first.
Yes.
Right. Like, yeah. In the history, I think, okay, is this musculoskeletal or do I need someone else to look at this?
Right.
Yes.
Right. So like, and I guess I should explain for people, there's different colored flags. Okay. There's two colors. There's red and yellow. So a red flag is maybe a sign that like, something's very wrong. We're not going to be treating you today. So, like, what's an example? Now that I brought
high
it up
blood
again.
pressure.
Yeah, yes, super high blood pressure, right?
Yeah.
Whereas a yellow flag is more focused on what's called biopsychosocial factors, and so things that would not stop a treatment, but they're going to affect the way that you approach a treatment.
Oh, yeah.
So like a really common yellow flag is called catastrophizing.
Yeah.
Right. Where people they're like, this pain is the worst and I'm dying and, oh, you got to help me. And blah, blah. And they're just really it seems like they're blowing things out of proportion. That's a yellow flag. If somebody mentions that they're unhoused, right? That's a yellow flag.
Yeah.
If they mention like a DV situation or they're out of work, there's all kinds of factors that go into things that might affect somebody's ability to heal.
Yeah, recent traumas.
Yes.
Can affect pain. So
definitely. Or even bad past experiences with healthcare providers.
Right. Yeah.
And then there's some formal assessments like the PHQ-9. I like using, like my favorite one to use is called Start Back. You ever use that?
I don't know that one.
Yeah. So Start Back is basically some questions about how the effect that people's symptoms are having on their day-to-day life. Like, oh, geez. Now I can think of exactly 0 of the questions on it, but it's 9 questions. And based on that score, it gives me an idea of whether I'm going to be able to rely more heavily on like a manual therapy with that person.
Oh.
Or if I'm really going to have to be more of a coach.
Okay.
Right?
Yeah.
And like, how much are we going to talk about your pain? As opposed to how much are we going to teach you to screw your pain and let's move into some function stuff. Let's not be your friend, right? And so then in my practice, what I like to do, the 2 techniques I like to use a lot for addressing those yellow flag patients are cognitive behavioral therapy and motivational interviewing. So both of those I found to be really pretty effective. And I'm not a psychotherapist or anything like that, but these are skill sets that we're teaching patients to use. The cognitive behavior therapy skill sets that we're teaching patients to use in terms of helping them to make SMART goals in order to focus on function, right? Motivational interviewing is like a reflective way of talking to patients, kind of help them examine and maybe solve some of their own problems. And so do you guys use any of that kind of stuff too?
No, I love the idea of this Start Back screening tool. I love that. I mean, I'm always listening for those kind of words that people use in their assessment, but I probably could be a little bit more intentional when I am listening, because it does change the way you treat people for sure. Yeah. If this person is hyper vigilant about their pain and catastrophizing, like you say, then you are going to ask a little bit less about the pain.
Yeah.
Because you don't want this to be focused on the pain.
Right.
Again, we want to focus on function. Like, what can you do?
Yes.
Yeah, and stay on the positive sides of things.
Right. Well, and that's like, and that's even where some like the motivational interviewing skills come in. Like, there's a technique where you might ask somebody to rate their ability to do something like, hey, Kathy, so, getting on and off of the toilet, right? Like, how would you rate your ability to do that on a scale of 0 to 10, 10 being like, it's like terrible, I can't do it. And like 0 is like, 10 being no problem, I could do it just fine. 0 being I can't do it at all. And maybe you say a 6. I might ask, okay, so why 6? Why not lower? Like, why wouldn't it be worse? Right? And so with that, it's kind of a trick because 6 is like, oh, yeah. And they're expecting you to just focus on like, how bad is it, And so it's like, you could ask like, okay, so like, what's that gap? Like, what do you need? What do you need? Like, we could focus on what they're missing. But when you ask like, why isn't it lower? Like, why is it all the way at a 6? They might be like, well, I don't have to have somebody come get me. And like, it's painful, but I can do it, and it starts getting people thinking about, oh, wait, hang on, that I actually can do stuff, right?
This could be worse.
Exactly, right? And so there's some skills and a little bit of kung fu that's involved in terms of communicating with patients in ways that help them to then solve their own problems and change their ideas about what they're experiencing. And then I adjust them.
Okay, well, let's talk about manipulation because that is kind of one of your primary modalities. Yeah.
And I miss it so much. I want to be able to adjust people. So
when you're explaining to a patient that you're going to manipulate, how do you explain it to them and why it's going to work or what's the purpose?
Yeah, well, first thing I do is I let people know they have no choice. They're getting an adjustment, right, regardless. And second thing I let them know is that the good news is that adjustments fix everything.
Oh, yeah.
Literally everything. Cancer, diabetes, heart disease. Disclaimer time.
Oh, yes.
Yeah. This is purely entertainment. We are not giving healthcare advice.
This is all
I'm not even serious about what I just said. So, no. When I approach the manipulation thing with people, it's spinal manipulation is a really good treatment for spinal stiffness. It could give some pain relief. It helps people be ready and able to get in a position where they can really rehab well, right? And that is my approach with it, is I want to facilitate you being able to do things for yourself to get yourself get better or to help yourself get better, right? Get yourself get better.
Get yourself better.
Yeah. And also the idea that most musculoskeletal things that people have happen to them are going to just improve on their own. They might not completely resolve, but they'll improve on their own. One of the challenges is that even though they improve on their own, they might come back. So, that's why they're here. It's not like I'm saying it's useless to go see anybody because you're just going to get all better on your own. That's kind of the patterns we get into is it gets better, then it gets worse and, kind of yo-yoing like that. But I very much focus on it as this is a tool that we can use to help you in your journey towards just becoming a more awesome you that has better abilities, better strength, better mobility, and it is a quick way to help get you to where you need to be. So, and you've referred people to me before too, and I think that that's why is because it's like, man, we are doing the right stuff, but there is something that could help kind of push you over the line a little quicker. And I send them to you too because I can do manipulation, but I'm not as good as you do it because you do it all day long. Thank you, Kathy.
Yes. I will give you that.
That one thing. Yeah.
But I also feel like sometimes too, like, people feel like they've gotten something when they've come to see you.
Yeah.
It's the pop. It's the crack.
Yeah.
It's the like, oh yeah, he definitely moved that bone into place. Whether true or not that you're telling them that, but that's what they think. And so, it also, what we learned, the way they taught to us in PT school, is it helps to reset the nervous system, right?
Yeah. And it can, like resetting, that's a really kind of good analogy.
That's probably a strong word.
Well, it's actually closer, I think, than you'd think. And one of the things people should know is we don't know everything about how spinal manipulation works, but you have a joint and that joint has a capsule surrounding it. And one of the things that's in that capsule is you have a bunch of nerves going into it. And when you do a quick stretch of that joint capsule, it stimulates all those nerves, and they have to kind of recalibrate and relearn, like, what's this joint's position in space and everything like that. So it is kind of like resetting in a manner of speaking or thinking. One of the theories is that you are rebooting the information that nerve gets.
That's so funny, because I was just thinking that's Control-Alt-Delete.
It is Control-Alt-Delete. It basically
literally
is. Yeah, it is. And the other thing, too, is popping a joint doesn't necessarily mean that there was a problem with it, right? Because all joints pop like,
whoa.
Okay? Those are my knuckles. I don't have knuckle disease, right?
You're going to get arthritis from that?
No. And actually, my fingers aren't healthier for having done that either. So it is, but it has effects. Like, I now have better manual dexterity with my fingers, right? In theory. So... But now that I've restored movement, this is where people really need what you do, which is it doesn't matter if you reboot that, if you're just going to go back to the same dysfunction.
Right. If your glutes are going to fall asleep again.
Yes. If they're going to become gluteal zombies, So let's talk about the role of exercise and rehab. So how is that different than kind of the stated goals with manipulation?
It's not. No.
Yeah.
A couple things as far as exercise progression goes. Well, first of all, if I see a person who is not a big exerciser, but is in a lot of pain and doesn't like to move around, and when they get pain, they do less.
Yeah.
Right.
Yeah.
So when I first get people moving, so sometimes it causes soreness, but the first movements and the first exercises we're doing is kind of the same thing that you're doing. We're resetting the nervous system. We call it in our profession neuromuscular rehab, right? And so I might give them simple exercises to do that might target the glutes or the quads without any weight. Yeah. And so we're getting that brain muscle signal. We're getting the brain and that muscle to talk to each other again. Wiring
by firing.
Yes.
A little neuroplasticity.
Exactly. And so, early on in rehab, that's really what we're getting to is more of the neuromuscular rehab. And then comes the part where we really try to increase strength. We're really trying to isolate the muscles. They did a good job in PT school teaching us how to isolate the right muscle and how to elicit the response from the certain muscles that we want to happen. We know how to take the deltoid out of an exercise and just get the rotator cuff. Right. So I think that is where exercise modality comes through. Like, even you might get a CrossFitter come in super, super strong person, right? And they might be able to deadlift 400 pounds, but they can't do it. They can't lay on their side and lift their leg up to the side because their glute med is so weak. So I feel like that is kind of the secret sauce when it comes to PTs. Like they teach us how to find people's weaknesses.
Yes, and exploit them for money. Technically.
And hopefully
think about it.
Actually.
Yeah.
Oh, man.
Yes, your dad would be so proud.
He would be so
you're getting money for exploiting people's weaknesses. No.
Exactly.
Yeah. And I think that's really really great. That's why I send people to you.
Yeah.
Is there's some people that they really like a good passive therapy. And it's like you said, they want to feel like something happened in the visit.
Yeah.
And it could be frustrating to start with physical therapy because the goal is to get strong, but nobody starts strong.
No.
Right. Yeah. And it's a process and it's progress. And I think what I know about physical therapists is outstanding assessment, outstanding coaches, and cheerleaders and guides through, hey, let's get you. One of the things I love the most is when people come back to me and they're like, I graduated from physical therapy. And I know what they mean, but it's kind of funny. But some places they even have, I mean, there is a celebration. I know that you guys do this too, where it's like even people that weren't working with that patient, they're like, oh yeah, you're doing it.
Good job.
Yes, high five. And so that it's magical for patients.
Yeah.
It's a big deal.
It's an accomplishment.
Yeah, totally.
Yeah.
And like I said before, they might have gotten better anyways. But on the other end of that, you think about somebody whose problem just passively gets better versus somebody who was taught to have an active, powerful, agentic role in improving their health. Like you have created somebody who now is going to be able to avoid the next problem. Right. So that's powerful stuff.
The power lies within them.
Yes. That's some real Yoda stuff right there. Well, geez,
we're getting close, but maybe we'd just do one case where we would treat somebody with the same issues, but how we can explain how we would treat it different or approach it differently.
All right. I have one.
Yeah.
Would you like one?
Yeah, let's do it.
This is Margaret. Hi, Margaret. Yeah, she's 71 years old. And she has a 3-month history of mid-thoracic aching that worsens with prolonged standing and household chores. She doesn't report any sort of trauma, but she also reports that she's lost about 1.5 inches of height since her 60s. She's postmenopausal and also not a real person. I should. People are like, whoa, he's just reading my history. No, this is not a real person, right? And what you also find out from her health history is that Margaret has osteoporosis. So Kathy, walk me through like when this patient comes in, maybe you're reading her history and all this stuff shows up on her history. What's your approach with her?
Yeah. Well, first of all, if I know that she has osteoporosis.
Well, and we already established you're going to meet her in the lobby because you're poor.
Yeah, we're poor. I cannot afford an assistant. I have to bring her back to the room. But that's one of the advantages.
Yes. We love you, Margaret. Yeah.
I will greet you at the door, Margaret. So if we know for sure she has osteoporosis, she had a DEXA scan. I'm assuming she had an X-ray.
Yeah.
So I can assume that there's no fracture with this achy pain, right? Okay. So my first assessment is a thoracic manipulation. No, just kidding.
Yeah.
How does this feel?
Yeah, bilateral, calcaneal, spinal. Yeah, which if you're wondering why she's laughing so hard, a calcaneal spinal manipulation is me standing on your back. It's amazing the number of patients who come in and they're like, yeah, I had like my kid walk on my back and stuff like that. And it's like, how many pounds of pressure do you think I'm putting into your spine when I adjust? And I have seen fractures from people having adults walk on their back.
Yeah, don't do it.
It's like, I'm sorry, you got to go to the hospital. Can't you just fix it? Yeah, I can fix it. That's why I'm recommending you go to the hospital, right? Oh, wait, you need to go to the ER or I could just do this. Oh, yeah. Why was I going to send you to the ER?
Yeah.
That's always the weirdest thing. Can't you just fix it? Oh, wait. Yeah.
I'll just do it here. Anyway. I'll save you a lot of time.
So anyway, you're not going to adjust Margaret's spine.
I'm not.
Okay, good. All right.
Her spine. Not at least, in the first 5 minutes.
Right.
Okay. And we've already assumed that she doesn't have numbness or tingling, and any bowel and bladder is great, right? Okay. So those
assessing all those things.
We check the red flags, right? So first thing I'll probably assess if it's thoracic spine, breathing. Does she have pain with breathing? I'm checking to see how she's breathing too.
So you're watching.
I'm watching.
Her breathe.
Yeah, and I might even put my hands on her ribs.
Okay.
To see how is she breathing. Is she expanding the bucket, or is that bucket lifting?
Okay.
Up and down. right? And then we are checking range of motion, thoracic rotation, flexion, extension, those kind of things, and see where her pain points are from there. I'll probably, just because I like to check above and below, so I'll look at the cervical spine, just make sure that, it's all connected, as they say.
That's my line.
Sorry. Yeah. It's all connected. So I'm checking cervical spine because maybe if it's, they're moving their neck, that might, cause some of their pain. So I want to make sure that it's not coming from their neck, which generally doesn't refer into the thoracic spine. But hey, you never know. Shoulder range of motion, definitely checking that, as those two are related for sure. So from there, I kind of need more information, I suppose, from there. But that's kind of where I start.
Okay.
Yeah. How about you?
Well, and real quick, like knowing what you know about her, like she's got this thoracic pain. She's got a history of osteoporosis. What kind of therapies are you thinking off the bat? Okay, this is how we're going to get started with Margaret.
Yeah. Well, for sure, I'm, after I've done all the kind of range of motion and all the other testing, I will probably think of more soft tissue. Okay. I'm going to think of, if I'm not finding anything in the assessment, I want to think about pain modulation, symptom management. Yeah. And if she has osteoporosis, I'm not going to do, high velocity. Sure. Manipulation from there. So I'm thinking more stretching. I'm thinking more. I actually may start her off with some shoulder exercises because if it is muscular, sometimes if it's muscular pain, it could be middle trap, it could be rhomboid. She's feeling the pain from. So I might let's activate the muscles. Right. Let's do some thoracic rotation exercises.
Cool.
Yeah.
I like it. Same patient for me?
Yeah.
Okay. So first, I have one of my assistants bring her back to the room in the golf cart or the Tesla, whatever.
The Waymo.
Yeah. And so then when she's in there drinking her espresso from our espresso maker, and like if we can get the door open because the gold is still in the way. Yeah. Shoot. Anywho, so I get in there. Margaret's in there. In a robe, silk, because that's what we do for all of our patients. I'm just kidding. Margaret's in her own clothes.
Okay,
all
good,
right.
good.
Yeah, and we're not going to take them off either. No.
Okay.
Not that chiropractor. So, no, but very similar start. We're going to go through, ask about those red flags. I want to know, like, first of all, where did she get the diagnosis from?
Oh, good point.
Right. Did she get this from her primary care doctor? Does she have any imaging results? Those kinds of things. So that'll be important to know. And a lot of times at that point, because people go to the chiropractor expecting to get adjusted, right? I kind of like to even plant the seed that, hey, have you been to a chiropractor before, and what are your expectations? And just know that because you have this osteoporosis history, we're going to be very careful with you, right? So we might use some manipulation, but we're definitely going to use some gentler techniques if we do, and a lot of caution. And I even start with that before we even get into the rest of the history, because it's important for people to know. I found that there's some people out there that are just crazy, and they're like, well, I came to get my spine adjusted, and so goodbye. So it's like, all right. And then we go through, do the history and everything like that. We're going to do a movement assessment. I look at general range of motion. We're going to do some spinal screening. So I think one thing that's really important in a case like that, I swear every single episode I get a call.
You do?
I do. Yeah. Last time it was my dad.
There's do not disturb.
I just got to get rid of the I should start using do not disturb. Anyway. One of the things that's really important in a patient like this, I think, is looking for areas of focal spinal tenderness. So touching those spots. And if you find a real hot spot, even if she's already had imaging, if she's got severe osteoporosis, she might have had an injury since being in the x-ray machine. So really identifying any sort of hot spots. and just careful assessment. One thing that I liked that you talked about was the breathing. Like I'd probably skip over that. I do ask about, do you get pain with breathing? But in terms of observing how she breathes, I think that's a really good thing that maybe
Thank you, Robin Pester.
Yes, thank you, Robin. And thank you, Kathy, by extension, for sharing. So we go through, we do some orthopedic tests. In the thoracic spine, there's not a lot of orthopedic tests, but like things like looking at twisting and then from there, it's a lot of education.
Yeah.
Right. So I need her to understand, where does osteoporosis come from? What are we going to do to keep her safe? What are the risks if we choose to do anything, whether it is exercises, manipulation, massage, anything like that, so that she can make informed decisions about what to do. And with people who have osteoporosis, with Margaret in particular, we're going to talk about the importance of three things. Number one is going to be resistance. You have to be working under resistance in order to help to save that bone density. Number two is nutrition. So making sure that you're getting good food, not just calcium. People are like, oh, I got to get my calcium. I got to get my calcium. But you got to get protein because you have to build muscle.
Yes.
Because if you don't have good enough muscle, the big risk with osteoporosis is that you're going to fall down, you're going to have a fracture, and you're going to die. Literally, you're going to die, you know. But it's a very common thing that people will have a fall. They have osteoporosis. They have that fracture. They go to the hospital. 5 years, within the next 5 years, they have a serious risk of dying. And so getting good nutrition, that's the calcium, the protein, all that kind of stuff, cutting out crap that causes inflammation that will further break down those tissues. And then the other thing is sleep. Making sure that you're getting good sleep. That's when the body repairs. That's when you can lay down new bone remodels and everything like that. A lot of times they're going to get a referral to physical therapy because I could tell them, hey, you need to go out and do some resistance exercise, or I could set them up in a situation to safely be doing resistance exercise. But telling Margaret, hey, go home, go to the garage, get on the old bench press and get it done, like, might be her last day. Okay. So yeah, those are the main things. If I feel like it's safe that I can manipulate her, I might do that. Manually, just very gentle pressure, the way I might adjust an infant in some cases. And then often, though, I'm using a tool because I can really, we don't have to do a lot of positioning and, you know, I can really control that impulse. So, yeah. And then I get Margaret on the 5 times a week for 72 weeks plan.
Yeah. Don't you think 6? Like, you should come in on Saturday and see her,
or maybe twice on Friday, something like that. Anyway, it's usually a conversation of how much do you have in your bank account, Margaret, and why. Like, what are you going to do with all that?
What do you,
Margaret? You're 71.
Come on.
Well, you got 29 years tops. What are you going to do with all that? No. All right. Well, that's good. I think this is a really useful exercise. I appreciate you sharing that because there's some things where I'm like, ooh, I could do that better. So
same.
Yeah.
Same.
Well, should we play a game?
Yes.
Okay, but this game, like, we've done enough talking.
All right.
What we should do is we should see if our star pupil has been paying attention.
Okay.
Our star pupil, of course, is Raul.
He's an A+ student.
He is. He is. Yeah. And so what I've done is I have created a bit of a quiz. They're comments, they're quotes, really.
Ooh,
well, kind of.
Who said what?
Yeah. And I want you to answer for us, Raul. Like, these are things that you might hear in a treatment room. So you call out whether it's a PT, a chiropractor, or based on what we've said today, or in the other, like, 9 months you've been working with us or something like that. Who does this come from, right? Is this a physical therapist or a chiropractor saying it? Does that make sense? Yeah. Okay, here we go. Oh, here, you want to help me read some of these? Yeah. That'll be funner. Let me see. Can I make this bigger? Because I know you got super old eyes. There we go. Yeah. Hey. All right. There we go. All right. I'll read this first one. And who reads the question is not an indication of where it's coming from. Right. So your atlas is out of alignment, and that's putting pressure on the nerve that runs your immune system. So, I like my disclaimer first that I read that.
Well, purely because you're the one who read that one, I think it's a chiro.
Yeah. So that's crap. But you're more likely to hear that from a chiropractor than a physical therapist. Okay, we'll give you a point on that.
Okay. Motor control before range. If she can't own the range she's got, I'm not giving her more of it.
Ooh, I think that sounds more PT to me.
Yeah, you're just saying that because she read it. Yeah. That is correct. That is
correct.
That is some physical therapist crap.
I feel like I've said
there.
That.
Yeah, exactly. All right. How about this one? I'm going to adjust you today. Then I'll get you on the roller table for 10 minutes.
Man, I can really hear that coming out of Kathy's mouth.
Yeah.
It's got to be a chiro.
That is a chiropractor thing. Okay. How about this?
Okay. Cuffs on. 60% limb occlusion pressure. 4 sets. 30, 15, 15, 15.
Sounds like a dentist. Honestly, I don't know.
Well, I'm going to give you a clue. So first of all, it's really confusing. So it's not a chiropractor. Yeah. Second of all, it doesn't sound like anybody's trying to sell you anything.
Yeah.
So what would you say based on that?
Maybe a PT.
This is a PT. Yeah, definitely some PT stuff there. And so what it's referring to is...
BFR, blood flow restriction.
Yes.
Yeah.
We did a whole episode on it. Mm-hmm. So if you're listening, you should go back, okay? How about this? I don't treat the MRI. I treat the person in front of me.
Kind of sounds like both of y'all.
That is correct. That is both. Good. Yeah, we say that a lot. And that's important. Sometimes I think people wonder, why am I not getting an MRI? Mm-hmm. It's because your MRI isn't telling us crap. Mm-hmm. We have very specific reasons that we want to see an MRI. It's we suspect that this is injured. Mm-hmm. We're not typically ordering an MRI because we're hunting for stuff. So, all right.
That was a grade 5 mobilization.
PT?
Yes.
Yeah, good job.
Yes, you went right back to the logic I gave you before. Does it sound confusing? Am I trying to sell you something? If it's a yes and a no, PT.
It's true. It's true.
All right. The pop is just gas coming out of the solution in the joint. The sound isn't the treatment.
That's a chiropractor.
That is chiropractor stuff. Okay, let's do 2 more.
She centralizes with repeated extensions. So we're going with a directional preference approach. Oh my God, these rules are spot on.
PT.
That is a physical therapist. Although I say that. I say that. So, okay. Yeah, I say that sometimes too. All right, we'll do one more here. Let the drop piece do the work. You barely feel it.
Not sure what a drop piece is, but I'm wondering if that's the tool that you use for adjustments. So chiropractor.
That is correct. Yeah, and I guess that's the other corollary. If we have to mention some sort of weird piece of equipment, especially a piece of equipment with a strange name, that is 100% chiropractor, right? We got things like a spinalator, activator, the drop release, the drop piece. You have the roller table, and you have the arthrostem, all those. That's all my crap, okay? Like, you guys aren't doing a bunch of that stuff. I mean, you got the Biodex.
We got the Biodex.
And a treadmill.
That's it. Treadmill, and we have a blood pressure cuff.
Yeah. And a bike. A stationary bike.
We do bike. NMES. Yeah. Don't forget our NMES.
NMES. Okay, yes. There we go. All right. Very good, Raul. You killed it. It makes me feel like sometimes you're paying attention. So, all right. Takeaways from today, Kathy. Take it away.
Takeaways are your assessments are pretty good.
Oh, thank you.
Yes.
You know, I feel like your assessments are good too. This is my takeaway is I was listening to the way that you're working things up, and it's like, yeah, I can definitely, like, why wouldn't I just add that in?
Same.
That would be helpful.
Same.
And it's not that I would be like taking your job. I still want to send people to you because I know what you're good at.
Same.
And I think more importantly, I know the experience that patients are having there. And that's really, really valuable. I don't care how people get better. I care that people get better. So it doesn't have to be by my hands. It just has to most importantly be by their actions.
Exactly.
So. We did it. That was a lot of talking.
That was a lot of talking.
I feel like that was a lot of talking today. So I think there's one more thing that we should say, and that's there's no I in pitch.